Number 7. Thyroid amyloidosis. Thyroid primary or secondary amyloidosis is characterized by the diffuse intraglandular deposit of an insoluble or amyloid protein. In cases of medullary thyroid cancer, there may be deposition of this protein in the glandular stroma, unlike amyloidosis, where it is also found in the follicles. The prevalence is low, reported in 0.04% of patients with systemic amyloidosis. Signs and symptoms: diffuse goiter, painless, and sometimes associated with tracheal compression dyspnea. Subclinical evolution is more common than the previous one, associated with both hyperthyroidism and hypothyroidism. Ultrasound findings: diffuse enlargement of the glandular size with hyperechogenic parenchyma, similar to the echogenicity of the connective tissue, and homogeneous echotexture of ground glass appearance. Sometimes small cysts can be seen. It is believed to correspond to dilated thyroid follicles. Reduction of the penetration of the ultrasound. Key points: diffuse hyperechogenic goiter. This picture shows thyroid transverse ultrasound. A. Evidences of a diffuse goiter, blue arrows, homogeneous and hyperechoic echotexture. Note the echogenicity similar to that of the connective tissue, red arrow, and the low penetration of the ultrasound beam, which gives it a ground glass appearance typical of thyroid amyloidosis. In B, there are some cystic structures that are believed to correspond to dilated thyroid follicles, orange arrow. In the axial CT without intravenous contrast, C, an enlarged and diffuse hypodense thyroid gland is shown. Kidney ultrasound in D shows a kidney of normal size with hyperechoic cortical and loss of corticomedullary differentiation, green arrow, suggestive of medial nephropathy. Another picture: this is cross-sectional thyroid ultrasound. A. Evidenced a diffuse goiter with isthmus greatly increased in size, 2 cm, blue arrow, homogeneous and hyperechoic echotexture. Note the echogenicity similar to that of cervical connective tissue, red arrow, and the low penetration of the ultrasound beam, which gives it a ground glass appearance typical of thyroid amyloidosis. Axial CT with intravenous contrast, B, and coronal reconstruction, B and D, shows an enlarged and discretely heterogeneous thyroid gland. In the coronal reconstruction, the large size of goiter and intrathoracic extension are observed. Number 8. Drug-induced thyroiditis. Key points: there are two types. Type 1, there is a pathological gland and increased Doppler. Type 2, there is normal gland and decreased Doppler. This table shows some of drugs and their uses and their effect on the thyroid. In this picture, a 58 years old patient on treatment with amiodarone who develops hyperthyroidism. Cross-sectional thyroid ultrasound, A and B, shows a diffuse goiter with multiple solid and cystic nodules, red arrows, with microcalcifications, green arrow. The color Doppler study in C evidences an increase in the vascular flow of the thyroid parenchyma, compatible with thyroiditis induced by amiodarone type 1. Axial CT of the thorax without intravenous contrast, D, evidences a diffuse goiter. And in this picture, a 67 years old patient on treatment with amiodarone who develops hypothyroidism. Thyroid transverse ultrasound, A, evidences a thyroid gland of normal size and structure. The color Doppler study shows a normal or decreased vascular flow. In B, a negative scan is observed, findings compatible with thyroiditis induced by amiodarone type 2. Here is a comparison between amiodarone-induced thyroiditis type 1 and type 2. In type 1, there is hyperthyroidism induced by iodine in a pathological gland. Ultrasound finding: diffuse or nodular goiter. Doppler parenchymal hypervascularization, More specific finding to differentiate type 1 from 2. Treatment of type 1 is anti-thyroid drugs. But in amiodarone-induced thyroiditis type 2, there is a destructive thyrotoxicosis induced by amiodarone in the normal gland. Ultrasound finding, normal gland. Doppler flow decreased or absent in Doppler ultrasound. The treatment of type 2 is steroids. Number 9. Diffuse sclerosing papillary carcinoma. Papillary carcinoma is the most common form of thyroid cancer, 75%. There are several histological variants, the diffuse sclerosing being a rare variant and more aggressive than the classical pattern. It is characterized by diffuse involvement of one or both thyroid lobes. Signs and symptoms are characterized by an important increase in thyroid size in the form of a cervical mass. It can be accompanied by dyspnea, dysphagia, and dysphonia. Ultrasound findings, multiple microcalcifications of diffuse glandular distribution, giving the parenchyma a hyperechoic and heterogeneous ultrasound structure. There is no clearly defined nodular lesion. Pathological cervical adenopathy are very frequent. Key points, diffuse microcalcifications, no nodular lesion. This is a cross-sectional thyroid ultrasound. Evidences an enlarged thyroid gland, mainly at the expense of the right thyroid lobe, red arrow. Hyperechogenic with respect to the adjacent tissues, and with multiple microcalcifications dispersed diffusely. In color Doppler study, B, an hypovascularization of the gland is evident. In a lower sagittal section, C, at the level of the right trachea, an adenopathy with pathological features, enlarged and microcalcifications is visualized.